here with us.
Oh, gosh. I just love that notification. All right. So I guess I'll go ahead and start for us, Chris, if you're okay with that. I'm going to go ahead and call the Community Health and Safety Task Force regular meeting for January 24th, 2023, starting at 5:36. And we'll start with the roll call, please, Valeria.
Thank you. All right, roll call. Renee Villarreal,
Present.
Bruce Finger,
Here.
Emily Kaltenbach,
Present.
Gino Zamora,
Here.
Mary Louise Romero,
Present.
Chris Rivera,
Here.
and a warm welcome to our dear friends who are presenting with us this evening, Nicole, Kate, Faith, and Faith. Back to you, Renee.
Great. And so just want to note for the record, Annie Rasquin is
Yes.
excused, Monica Alt is excused, and Marcela Diaz is will be a little late today. All right, great. We'll be moving on to approval of minutes from our January 10th, 2023 meeting. Did anyone have any changes? No. All right. Hold on a minute. Let's see. Okay. Is there can I get a second or a motion in a second then?
Move for approval.
I second.
Great. We got a motion and a second, and we'll do a roll call, Valeria, again.
Absolutely. Renee Villarreal,
Yes.
Chris Rivera,
Yes.
Bruce Finger,
Yes.
Gino Zamora,
Yes.
Emily Kaltenbach,
Yes.
Mary Louise Romero.
Yes.
Excellent. Thank you. All right, moving on to, we probably don't have much, so I won't change the order of the agenda, but communications from the co-chairs. And then we'll jump into communications from staff if there's anything we need to be aware of, and then we'll go to presentations and introduce our guests or have our guests introduce themselves. Is there anything, Chris, that you wanted to share?
I don't think so. I think we got a email from Gabe this morning that said that they had completed the 300. So
300 what? Can you elaborate?
surveys. Sorry, 300 surveys. So he sent some preliminary info on that, which I haven't had a chance to look at yet.
Okay, I haven't either because I was at my other job today. So that's good news. 300 folks reached, which was the goal for the survey for the community, first phase of our community outreach. Did anyone else have anything to share about that?
Chairwoman Villarreal, I have a question just as far as the other 200, and maybe when Marcela gets here, we can ask as far as sort of the status of that, and are we still recommending groups to connect with to get those additional surveys completed?
Yeah, I think, didn't you all already kind of set a preliminary list and then?
Yeah, I just can't recall where that is. And so I just wanted to make a recommendation that we add, and maybe seeing that we have a few of our guests here might be able to help, but whether the MIHO or ARU could reach out to folks they work with to get surveys completed.
Yeah, we can inquire about that, how that would work. Maybe we can explain that further. But I'm not in that committee, so I don't know if Chris wants to explain that, or we wait till after the presentation when we go into matters from the task force. What do you all prefer?
I'd recommend we wait because then Marcela will be here, and we can, between Chris and myself and Marcela, we can talk about those.
Okay.
and Mary Louise. Okay.
Chris, were you going to say something?
No, just the same thing I think that Emily did.
Great. Okay. More to come. We'll tell you more about that survey that is being facilitated. It was by phone, but there's another phase that of like small groups and focus groups. And I would rather have Marcela say a little bit more about that. So we'll move on to staff, communications from staff or facilitator, Valeria.
I have no updates or communications at this time. Thank you. Back to you.
I have no updates either.
Thanks. Thank you both. All right, then we'll move on to presentations. We have a presentation on community-based behavioral health management in Santa Fe. And we have a couple of guests with us that are presenting, and then there's other support staff that I don't know if they're going to be sharing any additional info, but we have Nicole Alt, who's our contracted behavioral health director for the fire department, and Kate Field, who's the crisis services director at the Santa Fe Crisis Triage Center. And I don't know if you all want to do intros about, your work or go directly into the presentation. And we have to make sure that you all have access to that. Do you have it to share, Nicole, or?
I think Kate was going to share, or I can share, but do you have it up?
Yes, I have it up and ready. Good evening.
Hello,
Great.
everybody.
I'll hand it over to you. Thank you for being with us tonight.
Thanks for having us.
Bear with me here. Okay, everyone see that okay?
Yes.
Great. All right, let me go back a slide. Stand by.
And if you all want to introduce other folks that are here listening, I don't know if they are going to contribute tonight or are they just here to listen in. So whatever you all want to do.
Yeah, I think Andres Mercado, Chief Mercado is here to sort of listen in and be a part of this. And then Faith Applewhite, Captain Applewhite is also on to listen. So they don't have anything to present, but they're here should we need them.
Excellent. Thank you.
Okay, shall we start?
All right.
Okay, so it's sort of a long title, the community-based behavioral health management in Santa Fe. It's a lot to say, but we'll dive into that shortly. So I'm Nicole Alt. I'm an LCSW. I'm the behavioral health director for the fire department. I've been with them for 5 years now. I'm a clinical social worker. I've done a lot of work with high utilizer programs, including the HUGS program through Christus St. Vincent, which is how I met the MIH office and then started working with them. So I provide mental health oversight for public safety response and case management, including ARU.
And I'm Kate Field. I am the Crisis Services Director for New Mexico Solutions. And that essentially means that I'm the clinical director for the Crisis Triage Center that we have here in Santa Fe and the Mobile Crisis Response Team. Previous to this position, I was at Presbyterian Medical Services at the Guidance Center and supervised the Mobile Crisis Team there, as well as the Bridge program and the Assertive Community Treatment or ACT program. And just prior to my behavioral health career, I was a former firefighter EMT with Santa Fe County Fire, which continues to inform my work every day. So we wanted to start off with just offering a little perspective or framework around our services. Unlike your traditional mental health services or counseling services, community-based behavioral health intervention looks pretty different. I know that most of us here are familiar with the social determinants of health and perhaps Maslow's hierarchy of needs. When our services go and intervene with clients and respond to clients in the field. We are meeting people at the very bottom of that pyramid with the physiological needs. They're concerned about food and shelter and safety before we can even talk about what their behavioral health needs might be. The middle paragraph there is really, it captures what's special about community-based outreach programs like ours. So we can go out and meet clients where they are with what they're ready to do, what they're ready to talk about. We can help them put words to what they might need and what they're ready to talk about. And going to them in their environment repeatedly over and over again, it isn't just one, creates a relationship that we can then build from to form continuity of care. What makes this possible is the partnership of Mobile Integrated Health and the ARU, and then the Mobile Crisis Response Team and our Crisis Triage Center. They all work really well in tandem and allows us to really provide solid answers and stabilizing resources for clients.
So a little bit, I stole most of this right off the city website, so it might look familiar, but a little bit of information about MIH and ARU, and some really awesome pictures of these wonderful people that I work with. So it's a collaborative effort between police and fire and community services department. We have 2 units running now, and I want to give a shout out to a bunch of people tonight who are on working for Code Blue tonight, looking for cold people, trying to get them into shelter if they would like to, or making sure they have hand warmers or whatever. So we do that also, but the ARU looks at the 911 calls coming in and decides which ones are a good fit for them. There's a lot of disorderly calls, a lot of welfare check calls, some psych calls, those types of things. They can also be dispatched out by another unit asked to respond. And people now in the community, I find, are calling 911 and asking for the ARU to respond to certain scenes. So we have a paramedic and a case manager. Everyone here in my office is trained in crisis intervention, extensive training in what social services are available. And then we've got backup from the police department if needed. So that's our officer, Stephen Lopez. He rides in his own vehicle, but he is available to ARU every time that it is running. So that's that. I bet you guys probably know a bit about that.
And probably know a little bit about this as well, but I'll just capture the services at the center. The center and the team are funded by Santa Fe County with some very minimal Medicaid funding, which is just starting to roll in. But it's quite a gift to our community. The center itself is Monday through Saturday, 8 a.m. to 10 p.m. as far as operational hours. It started 8 to 5 Monday through Friday, and so we're slowly building up and expanding, and we'd love to see those hours continue to expand. What with staffing and exposure, I think we're headed in that direction. And what it provides is immediate intervention, low barrier. So as long as someone is voluntary and medically stable, they are welcome to come in and work with us. We can provide a little medical triage. They can work with a peer support worker, which can be very powerful. They can see a clinician, of course, start working with a case manager to develop a plan, and also get a little bit of respite care, which can mean a nap or a shower or laundry or a meal. Quite often folks will not come into the center just once. They will present with some very complex scenarios that requires multiple visits over, say, a month or 2 months, depending on what we can connect them to. We also support families and caregivers quite often. daily, really. And then, of course, the mobile crisis response team, which has been around since 2014, has always operated 24/7, 365, and it has consisted of a team of a clinician and a case manager or peer or EMT recently. And we can respond anywhere within Santa Fe County, but we are operating through 911 dispatch. So we are a co-responding service. And whenever we have a request from law enforcement or EMS, whether it be PD in the city, county sheriffs, county fire, state police, they go to dispatch, we get a call, and we go out to the scene. This can make a huge difference in linking individuals who are experiencing a crisis in the moment at a scene or in their home, or they've lost a loved one. We can go out to them and be with them in that moment. And then after the crisis, support them to get to some long-term service or identify what else they might need. And certainly we prioritize trying to support law enforcement and first responders, EMTs, that are often left to navigate behavioral health calls on their own in the community, and facilitating ER and jail diversion as much as possible. There we go.
Great. I just want to add quickly that Kate and her team also provide a really nice selection of groups that our clients that we co-work, or clients that we have in MIH can access. So that's a really powerful thing too, to have groups that are sort of in response of what people are saying that they really need. So just mentioning that. So the partnership. So as we all know, there are shortfalls in outreach, there are shortfalls in mental health services across the country. It's not just us, but it does mean that if we have this type of response, this progressive community-based program, we are heavily utilized. And we can be very effective because we can be out in the community and we can respond to these things that a lot of the brick and mortar stuff can't, but we also are filling in gaps and creating safety nets in between different service gaps. So they're also just we're barely scratching the surface of the larger societal issues, things that, Kate mentioned, and the hierarchical needs, housing, safe spaces, things like that. So it gets sort of bottlenecked by the minimal services that we encounter. So we can be out in the community all we want, and then it's difficult to find openings to get people into the services that they need. So that's just a little piece about that. But our partnership, so people have asked, why do we need both? And I think Kate wrote this awesome little part about how after mobile crisis response was started, it became very apparent that there was a huge unidentified population that was going to be accessed only through this type of outreach. And that these scenarios and these people that we're encountering have really complex issues and complex scenarios in their lives that touch a lot of different places. So it's, there's some therapeutic needs, there's some medical needs, there's some social needs, there's all of those things sort of coming together. So it was identified that that response, the mobile crisis response, really should and naturally fall within public safety in order to be safe for the mobile crisis response, to be safe on scene, to sort of make sure that we're all doing things in a transparent way. And so, out of that came some of the mobile integrated health office services. So because we are a nimble office, the ARU is a very nimble machine. We can triage a lot of scenes when we get on scene. So we have the capacity to get on scene, respond to a call, not, either cancel somebody else or co-respond with a police officer or the fire department, see what needs to be happening, and then we can decide where that needs to go next. So oftentimes we do call mobile crisis. We're starting to call them more and more. We also regularly transport people from the scene to the crisis center that Kate operates. That's an open door policy for us. We have a key card. It's going very smoothly. It feels like a very embedded part of the public safety system at this point. So having a licensed clinician on scene with mobile crisis really opens up a lot of things. There can be lots of diagnoses and diagnostic assessments done. Things like certificates for evaluation for people who are refusing to go in for care, but really need to for the safety of themselves and the community members around them. And also navigation to like trauma-informed services and getting them to the right hospital, and then also following up with that to make sure that the person gets what they need. So that's sort of how our partnership works and why it works so well to have all of us working on this issue.
We thought we'd offer a little bit of a story or a narrative about a client, a typical type of client that we work with anonymously, of course, that might illustrate why you need both services and how they work. We recently had an experience with a client that I have worked with since 2014, since the first days of mobile crisis. He has no fewer than 20 arrest bookings and no fewer than probably 40 ER contacts this year. He's someone that's been homeless with a severe mental illness since his adolescence, and has no family to support him, and has been through our system over and over again through competency hearings and found not competent, so charges are dropped and then he's back on the street because we don't have the next steps here in New Mexico. We don't have the intervention that would involuntarily put him into appropriate treatment. We don't have an institute that could hold him essentially his whole life, and he's severely functionally impaired. So this person lives at the jail and the crisis center and the ED and on the street, and you can find him pretty much anywhere with the three agencies at any time. He utilizes a whole lot of resources in the community, and nothing about his predicament is going to change until an entity is able to intervene with identifying a plenary guardian for him, which is expensive and takes a lot of time. This individual last week left the crisis triage center, as he usually spends days here, goes out into the community later in the afternoon. The ARU encountered him. He was walking down the street in multiple layers of clothing. He also had a black stocking cap over his head, covering his face, and a rope around his neck. This is the type of scene that takes some careful assessment, right? You need to move slowly through it. Is it appropriate for a police officer to respond to this? Is it appropriate for a paramedic? Is it appropriate for a clinician? Probably all three, right? So you need to have access to all three so that you can engage this client, assess whether he's safe, whether there's substance use involved, whether there's a medical issue involved, if he has any intention to harm himself or others, and then be able to navigate him to the next best resource. So maybe that's an ED, maybe that's back to the crisis center, or maybe it's just supportive social services like food and shelter.
Yeah, so to add a little bit to that, somebody just turned off all my lights. Thank you. To add a little bit to that, so when we have spent a lot of time, Kate and I, and the hospital and the jail, and his guardian, trying to figure out how to get him what he needs when we have him. And unfortunately, what we learned this last time around was that the only place that we were really able to get him the long-acting injectable medication that helps him was in the jail, because the jail will always take him and they always have a bed for him. And so they did take him, and we did communicate with the jail, and he did get his injectable, and that was very helpful. But, it sort of shows that even with all of these, positive touch points that he's got, things that we've worked on for years to get him connected to, even with those, without him having some of his basic needs met and us being able to find him and make sure that he is safe and warm, we have to do all this rigmarole like throughout the whole community. So I think he's a good sort of example, and he's not alone in terms of being this type of community member. We encounter quite a few of them. So yeah, he has a special place in all of our hearts, I think.
Here's a little bit more detail on what the response looks like, the practicalities of it. So essentially dispatch will receive and then send out the appropriate responding agency for a psychiatric issue, could be disorderly conduct, could be man down, could be a welfare check. You don't really know. And dispatchers don't necessarily have the luxury to have all the details, right? So you dispatch quite often law enforcement, quite often EMS. The alternative response unit has the flexibility to watch the queue, the calls coming up from the CAD, and then respond to the appropriate calls where they can be most effective. And that might be also including mobile crisis if it's appropriate. As I mentioned before, the mobile crisis team also responds with other agencies in the county through dispatch. The call could look like anything. You have to be flexible. You have to have time and access to resources in order to develop and provide a safe outcome for everybody. And you never know what that outcome is going to be until you're there. You have to assess for safety. You have to assess for symptomology with the patient. And it could be they go to the ER, or they have a family member that can help them, or they go to the crisis center, or they get navigated to outpatient care of their own volition, which is probably the exception. Most of the folks in this category that mobile crisis and the area you're responding to are individuals who cannot access standard traditional outpatient care because of their functional impairments, because they have severe mental illness, but they are also not sick enough to warrant meeting criteria at emergency departments. So there's a big gap in there, big gray area that we have to take time to navigate. And then, of course, the response itself is just a drop in the bucket as far as the work involved in supporting someone like this. You respond and then the work happens after. So intensive case management is profound in getting someone stabilized. And any provider that's going to develop a treatment plan is going to have to kind of throw out the net and see where this person's contacts have been. Are there court records? Is there health information exchange data? Public Defender's Office, MIH office, of course, the Connect program, the jail. You want to look at all of these so that you can start connecting the dots and develop an appropriate plan. And most importantly, get an idea of what the barriers have been for this person in accessing resources.
So I have a little Post-it note on my computer that says impaired judgment due to psychosis. And I look at that a lot when I'm trying to figure out, what's happening and how I can try to explain to an ER nurse or something what is happening. So I just keep that there as a reminder. So our collaboration touch points and what we do. The complexity of these needs, as we've said before, requires a large network of providers and people that can respond. So that means the alternative response that we provide is immediate on-scene intervention, extensive support and navigation to appropriate stabilizing services through multi-agency, collaborative, person-centered advocacy. And the case management, which I think is sort of the crown jewel in my office in a lot of ways. counseling, medical triage, outreach, transportation, and care coordination. We talk to people, everyone from a nurse at the hospital to a case manager somewhere else to a care coordinator from the insurance to, I mean, it's a wide variety of people. So the intersection of that multi-agency response means that there's a benefit to fire and law enforcement across the community. They don't have to respond as much. They don't have to try to figure out things that they do not have the time, the training to do, and we can do that. So it's a big benefit. We have quicker and more comprehensive answers to those in need. So what we might know just off the top of our head, or some of my case managers are just amazing at having resource ideas and connections in the community. What we can do very quickly typically would take somebody who isn't involved in this work a longer period of time. And then the effective identification of an efficient resolution around those gaps in services. So that's just another example of that, that web that we are building that fills those spaces that are gaps in services. So there are a couple of things. I thought this was interesting to just help paint this picture that since we started doing the ARU, I wasn't fully aware of how that work was going to change my exposure and my understanding and my ability to try to intervene in the community and what we're going to find. And we have found so much. The more we look, the more we find. So I was surprised by the number of elderly and isolated community members, especially after the pandemic. Elderly people who have no family were extremely lonely and isolated during the pandemic and are now trying to sort of reconnect, but maybe they've had a significant decline in their mental capacity. So we're seeing a lot of dementia and Alzheimer's and all of that, which presents in all sorts of different ways. You know, those calls tend to come in for police because they are welfare check calls, or disorderly calls because the person is in conflict with their neighbors because they're confused and things are happening there. So that was a surprising piece to me. So we've done some training with a dementia expert, and that training was really fascinating for me. So then, of course, the unhoused individuals that just can't access those services, like Kate said, they're just, you know, they can't make it to appointments. They can't, you know, show up and accurately explain what they need, fill out huge intake packets, those kinds of things. And then individuals experience psychosis that don't meet that criteria. So they can't, they won't go to a mental hospital because the insurance won't pay for it, and they can't be accepted to one of those. They don't have the capacity to achieve that outpatient care on their own. So, you know, we do try to work a lot with outpatient psychiatrists, and still, you know, unless we drive them there and make sure that they're getting there, it's a huge challenge. And then dual diagnosis cases. So this is a really big part, a big faction of the people that we're dealing with on the street. So this is somebody who presents as maybe they're schizophrenic, but we also know that they use meth or they use any number of substances, right? And what happens is that the substance use trumps the mental health issue, and they don't get the care for that underlying issue that they're experiencing. A lot of that substance use stems from trying to self-medicate with their symptoms that they've had their whole lives and side effects that they have from medications and all of that. So it's pretty difficult to find a place that will really be curious and assess a person who we know to be schizophrenic and actively psychotic, who is also on a substance.
There's some relief from the dark picture, and it's really nice to be able to provide this list of things that work and things that are going well. Just in my 8 or 9 years in behavioral health, I've watched these things develop with our programs, and we are making up for massive dysfunctional nationwide system failures, right? From the time of Kennedy, we are filling a really big gap here with our work. What we are doing really well in Santa Fe are these following things: the public safety agency coordination, which is beautifully exemplified by SFFD and SFPD working on the ARU together. Access to the public safety infrastructure. And this essentially means that in order to safely and appropriately respond to an emergency call out or community call out, you need to have access to dispatch. They need to know where you are. You need to have radio communication. You need to be able to contact law enforcement if there's a safety issue, or EMS if there's a medical issue. Nothing stands alone. Having clinicians out in the field 24/7, boots on the ground, getting those counselors and therapists out of their office and providing assessments in the field in real time is pretty remarkable. And clearly that's where we're going as a nation moving forward. Let's see, the partnership between all of the agencies that allow for crisis resolution, patient care. It's really the care coordination between the agencies is pretty healthy, and providers are very open to receiving, for the most part, calls from us when we're looking to connect or find a history about a client or coordinate the next steps for them. So that's been great. Having the crisis triage center, certainly a game changer. Having done the work out in the field without the center for many years, it is a real luxury to be able to bring a client back to a safe space and provide them with a little bit of shelter. Continuous person-centered problem solving. So that means back to, we meet them where they are. The client tells us what they need, what they're ready for. We take baby steps with them, and their treatment plan is just for them. It's individualized. There's more of the provider interaction. We're on the phone every day. We're texting every day. We're debriefing on cases, and it needs to be constant. You need to know where people are. I have your client here. They were at the jail 2 days ago. Now they're in the ED. Inclusion of stakeholder agencies in planning and development. And this I have been able to witness in the Santa Fe County Behavioral Health Strategic Plan, and watching them over the years include all of the participants. So the outpatient clinics, the hospitals, public safety agencies, all participating in the plan because it makes it realistic and attainable. And then, of course, supervising of the program, you have to have that supported oversight so that you're making good decisions and you're building a healthy program that's ethical and responsible and well-staffed. And then we're very fortunate to have the ongoing support, of course, from Santa Fe County and the city of Santa Fe.
So, hopeful future. This is the part where we thought we might share a couple of things that we are thinking about, and also acknowledge some of the things, that areas that we know we're working on currently. So collaborative and informed growth between city and county. So that means we don't want to double up. We want to be in communication with each other. We want to try to make those decisions together so that we can provide the right level of care and the right staffed care. Building out some of the existing community programs, because we can't build everything from the ground up. There are agencies and programs out there that, you know, the city funds a lot of them, the county funds programs. Those are the places where we can really, you know, inject a little extra oomph and see what comes from it. Continued structural and budgetary support. So just making sure that we're growing things in a way that we continue to hold the whole system in a healthy space. You know, it's sort of like if you have a triangle, you know, you have all the stuff at the bottom, but if you flip that triangle and you just try to build from up here, you know, it's not going to work the same way. So having that structural foundation and recognizing that if you're going to grow, you need to grow from that place. And so we talk about that a lot in my office. Kate and I talk about it a lot as well. So that's the careful growth piece. And then that our system is episodic illness driven. So I'd like to see us, and I think we are moving in that direction, moving away from episodic care in general for behavioral health, for medical health, for community health, and towards the longer view, right? We want to see a longitudinal plan for people, families, communities, agencies. So I noticed one of the things that you all in the task force have said that it stuck out to me was the idea of a community health driven practice of public safety. So that means that we are looking at our community to understand how healthy our individuals are and vice versa. In my mind. So I think if we can look to the areas that we know we need help figuring out and moving forward with, then we can have that community health driven practice. And that the calls that aren't being managed by hospitals or outpatient facilities often fall to us. So those gaps in those areas where, if we can't get somebody into a mental health facility through all the places that we try, that person and the calls are just going to keep coming and they fall on ARU or mobile crisis. And then without mobile crisis or ARU, they fall right back on public safety. So they fall on law enforcement and they fall on EMS. And I think that with the structure that we have been working on, we can help bolster that up and keep that from happening more and more. So I would just like to share a couple of things that Kate and I talk about a lot, and a few things that might be on the horizon in our minds. So a safe, sobering facility, a medical sobering facility that is truly accessible and can handle dual diagnosis, can handle multiple like polysubstance use, complex polysubstance use and trauma, inpatient stabilization for co-occurring disorders. So that means we have this amazing crisis triage center that Kate runs that is a huge help, and we all felt it when it started that this was going to be helpful. And we need emergency stabilization that can hold people for a long period of time. And we need to have that in order to keep that person from cycling, like the one that we talked about earlier, through all the systems where he can't go for 24 hours without encountering at least one of those systems. And then we need a lot of adolescent and youth behavioral service expansion. So I'm happy that we're discussing that. I know the county is talking about that quite a bit. The city has been helping me connect with the public schools and the wellness centers, and also with the Sky Center. So I feel hopeful about that. And we need to keep the access to help timely, and the outreach takes people to open doors, and we need safety and that bottom tier of the Maslow's needs, safety, shelter, housing, food, those things we are addressing as a community. We need to keep digging hard into those. And then healthcare, both medical and behavioral health. So recognizing that behavioral health care is healthcare, and that we need to invest in it, and we need to take it seriously, and we need to continue to build out systems to help treat it. I think that's our last slide.
It is. Thank you for allowing us this time this evening to talk with you all. I imagine there might be a question or two.
Excellent. Thank you, ladies. Oh, let me move my screen over here. I was curious from your last presentation at the quality of life. Did you modify this presentation based on, I was like, these are my questions that I asked. I was like, oh, maybe I just missed it in their presentation. So you did modify it a little bit. Okay,
We
good.
did,
All right.
we did. We
Is-
want to be responsive, and we also felt we were excited to have people ask us, what do you need? So we allowed ourselves to dream a bit and share some of those ideas with you all.
Excellent. And I will ask that again in a bit, but I'm going to open it up to other task force members to see if you have any questions or comments of our guests. And just want to acknowledge Andres Mercado and Faith Applewhite, who are instrumental in this team as well. And we've actually had them present in the past. So thanks for joining us again. Let's see. Does anyone have any questions? If you want to raise your hand or just let me know. I know you have questions. Great. Emily, go ahead.
I was trying not to jump in too soon, but well, Nicole and Kate, thank you so much for that overview. I think it was the best presentation we've had to really give us a really clear picture of what's actually happening and some strong recommendations moving forward. And it really, Santa Fe is so lucky to have this model. I work with a lot of communities around the country, and everyone's sort of struggling still. And I feel like Santa Fe has always really been a step ahead. And so, thinking about how we can make it even better. So I have a lot of questions, but I'll try to be, I'll narrow it down. I'm curious first about sort of the criteria around engaging with law enforcement. Is that sort of at the discretion of the folks in the field? I know there was one slide that said law enforcement comes to every call, or are they just called by various units to come? So I'd love to hear a little bit more, and has there been sort of a sit down conversation around what that criteria looks like? That's my first question.
Sure. Thanks, Emily. You can always email me a bunch of questions if you have more, but I haven't seen you in so long. It's nice to see you. So we are in communication, pretty regular communication with PD and the higher ups at PD. And they are very aware of what their requirements are on scene and when they need to respond. And we have been very diligent about figuring out how to triage that before we even go on scene. So there's a lot of research that can be done into an address, into an individual person who's named, and we can make phone calls to the 911 caller. We can do these things to help set up the scene so that we know a little bit better what's happening. And I do think, at the beginning of ARU, we had an officer on the unit. And she was fantastic and super helpful at building out, sort of feeling out what we needed. And then when we realized that we didn't, she wasn't needing to go to the door with us all the time, or, she was in the car more, sort of monitoring and being, super awesome to have her there. But we realized that we could have, if we had an officer who was available to strictly to the ARUs, that was his priority during the day, that feels pretty good. And we've also built out, really strong relationships with all of the PD officers on scene. So those scene relationships, and everybody has each other's cell phone numbers, and we're always sort of calling and figuring out what's going on. So that's sort of the way we've been addressing safety.
And of course, 911 dispatch protocol for any behavioral health call, law enforcement is dispatched automatically.
Mhm.
So that's the blanket safety net. That's a lot of calls for our department.
Yeah, thanks for that, because I think one of the things we've been sort of thinking about in this work is how do you at that first call maybe not have to have law enforcement come to everyone, what does that look like? And I think there's a lot of folks struggling with what does that criteria look like? And so just wanted to flag that, because I think that is something our group has talked about, of just sort of that alternative response that starts immediately at the call. And is there a way to do that? So yeah, thanks for that info. two other real quick questions. One, sort of the voluntary nature, and if folks don't want to participate, like how do you deal with that? What is the trigger? And sort of again, meeting people where they're at. If they're just like, sorry, don't want to engage, how is that dealt with? And then the other one is more of a sort of a policy administrative question of capturing, how are we evaluating? Are we capturing saving? Like, I'm just curious of like, what does success look like? Like, what are the outcomes that this collaboration, so from the crisis center to ARU or MIHO, like what are you actually measuring to show that it's successful? So thanks, sorry, those, and I'll email my other ones.
I thought you were supposed to stack questions like that, Emily. Kate, do you want to go first on that one with the voluntary and involuntary?
Yeah, sure. So that's really where that clinical piece, you kind of hit the juncture there of why it's important to have a clinician involved in the field response so that you can assess if they're involuntary, are they unsafe? Are they going to meet criteria to be seen in an ED, right? Is really what we're talking about. Or is there suicidal ideation or homicidal ideation? Because they can be involuntary, they can refuse care. And if we are deeming them safe to go out on their own recognizance after an episode, that should be a behavioral health provider's call, right? Ideally, it's a lot to ask officers and EMTs to do that over and over again. So if we determine that they are unsafe, we feel they're unsafe, we will write a certificate for evaluation, for emergency evaluation. And that is simply a request. It is a document that goes to law enforcement asking them, well, it's an order, they have to transport an individual to an ED. But then it's the ask of the ED to provide a psychiatric evaluation. And it doesn't mean that they're going to get an evaluation. It just means they're going to be transported there, that we are concerned about their safety. It's a very tricky thing, and New Mexico hasn't done a fantastic job in our legislation around behavioral health and involuntary treatment. But more to the point, you need someone involved who has that expertise and licensure to make those decisions.
Mhm. Yeah.
Second question, Nicole.
I don't know where to start. Where should we start? Okay. Well, I mean, I think Andres just sent me a little text just to remind everybody that 80% of our calls are handled without PD. He's the data person, so is Faith. So Emily, can you repeat the last part of your last question?
Sure. Maybe I'll just say, what does success look like to you?
Yeah.
Like that these programs are working.
Yes. So there are a lot of tiers in my mind of success. And I think we talk a lot in my office and a lot in behavioral health in general about what success looks like. And my version of success has changed a lot in this work. A big success for me is to build relationship and have somebody vulnerable and in need of services trust you enough to help them get to those services. That always feels like a success. Success feels like having enough communication with all of the partners around a certain person's care that when they hit a system, we've done this work to help figure out what needs to happen next. So they're not just floating. And we try to get, notes and charts and things in dispatch and all of these areas to do that. That feels like a success to me. I think just having, having that different response out there feels like a success. Seeing the EMS captains and case managers and clinicians from Kate's team and EMTs and nurse, all those people on scene providing care to somebody is a success. And it really makes me feel proud and humbled and all of that. So those are some of my things. We do capture data, but
And so do we, but it is difficult to demonstrate a negative number, right? If you're trying to demonstrate like how fewer patients the ER is seeing in a period of time. What you can, of course, calculate is how many encounters we have. And so, for example, at the crisis center, when they started, we were seeing like 1 or 2 people a day as people were learning about us, how to use us. Now we see about 250 people per month, right? So those are encounters that would not have happened otherwise. Those people would have no contact with a provider unless it was 911 or an ED. So that's kind of a nice way to capture our data. The other pieces that we have are how quickly we respond to someone and how many people get assessed that otherwise would not have occurred.
Thank you.
Thank you so much. Yeah, I think I just want to end with saying, these programs are invaluable to our community. And so as we think about recommendations, how do we bolster them and, figure out ways that we can really show the outcome and the impact to individuals and community, that it's making a difference. I mean, I think what that case study you showed is just, to me, so upsetting to hear that individual had to get his medication in jail. Like that we're criminalizing people to get healthcare is just, it's so wrong. And like what can we do as a community to make sure that doesn't happen again? Because that, to me, is a failure of so many systems that we have to rely on the jail for that type of service. So thanks so much for.
Yeah, I mean, I think I was really excited to talk with you all because I remember when the task force started, I felt, I could feel that what we were doing in this office was a part of that, was going to contribute to this. And I do think, just, what Andres reminded me of about the 80% of our calls don't have a police officer on them. I think that is a success, and that is some data that we can really hold on to and remember. It's not only, I mean, it's extremely helpful for the police officers, and they're so busy and taxed, but also, I mean, it's a whole different experience. So that's a big deal.
Emily, did you have any other questions? No.
No, thank you so much. Thanks for the
If you
time.
do, we can circle back around for
Okay.
sure. If you want to. I will, let's see, Bruce, I see your hand up.
Yes, thank you. Appreciate you both being here. It's very, very important. I was in the field for a long time. I saw a lot of what you described in your presentation, the individual that is. Many times they wanted to be arrested because they would have a place to sleep instead of on the street. So that is a sad situation. I saw is there some plan or thought to opening up? And I think I saw it in there where you're going to have a place for people that are in need, like this gentleman, that they can go besides, a lockup where they're going to get meds and food and one place to sleep.
That is the ask. That's the ask, and the hope is that we could provide a facility that could be a stabilization point. And then, what we know needs to come after that is supportive housing for people with mental illness who maybe need to be need to stay in that housing, as ordered by a judge or whatever that looks like, but somebody who is getting their medications and their needs met. Because we do have, I recognize that this is not every patient. Obviously, I take it very seriously, as Kate does too, when we take somebody in against their will or try to do something against their own personal will. But we do have people that are really just not able to care for themselves in a grown-up world and in a dangerous, scary world nonetheless. So, yeah.
Another question, what, I'm thinking, won't the dispatcher that takes the call for service, do they become part of the screening, whether or not a law enforcement officer is gonna respond also? Is that part of it, or is that determined solely by the first person who shows up?
Well, it's typically determined on what the caller reports, right?
Okay,
And they have a pretty tough job in trying to determine, is a man down, gonna need law enforcement, disorderly conduct, is that gonna need EMS? Hence, I think a fairly rigid protocol in having multiple units respond, right? And then being able to triage along the way, which is what the ARU does so beautifully, is so smart, to be able to cancel law enforcement, for example, if they're heading to a call sooner. But as it stands now, any behavioral health call gets everybody until someone intervenes or further notice.
that last question, what's the staffing now? Like, I remember when it first started, you had like one unit, Monday through Friday, 8 to 5, or something like that. Have you added more?
We have. So we now have 2 ARUs. We expanded and hired a second EMS captain and experienced paramedic to run. So we still don't have a whole lot of out of business hours. We're working on that. It's a complicated thing with people's schedules and unions and all stuff that I don't understand. But we do have 2 units. They have overlap days. So sometimes we have 2 units running. And when we hired that EMS captain, we were also able to hire 3 more case managers. So we now have 2 EMS captains, 7 case managers, 1 case manager supervisor, an EMS or MIH paramedic, myself, Andres Mercado, and then we have some other EMS people that are really helpful. Faith helps a lot with, she jumps on the unit. She also does a lot of data and stuff that really help us build out programs.
Good, thank you. Appreciate it.
Thank you, Bruce. Anyone else from the team who had any questions or comments? Mary Louise, no. Gino, Valeria, are you raising your hand?
No, I was just noticing, Kate Field, thank you for including your contact information, and we would love, if it's okay, copies of the slide deck so that this team can reference back to those later as a resource. Thank
Sure.
you. And
Gino, I think you had it.
Just one observation from your final slide. I really do appreciate looking forward and toward enhancing behavioral health resources for adolescents. It's that chicken or egg thing. If you're helping them earlier in life, hopefully they're developing those tools for later in life, and you're lessening the adult need. So I've just been in my head since reading that about, wow, how can we get to the adolescent behavioral health services as quickly as possible, because hopefully that takes them out of the cycle as adults.
Yeah, early intervention is huge. So there are cool programs that are early intervention programs for kids with some of the psychotic disorders. So the earlier you catch it, the more inclusive and wraparound you can be with care and services.
Right.
The better the outcome.
Couldn't agree more. And I know in a perfect world, we would have a crisis triage center just for youth. Of course, with state regulations, you can't treat youth and adults in the same facility. But I think it would be a huge resource for families and kids and adolescents in our community, perhaps in our future.
Great. Well, thank you for having your eye on that. My day job is with school districts throughout the state, so I'm more acutely involved with with crisis intervention at the high school level especially. So thank you. Thanks for having that vision.
Thank you, Gino. Let's see. I see Sarah's, but was there, Chris, did you unmute for a question?
Yeah, if everybody's done, I was just gonna ask, and I don't know who's best to answer this, but is there still a mobile integrated health office?
Yes.
Okay, and then there's the ARU. So can somebody explain what the job is of both those different units and how they either work together or don't?
Sure. So the Mobile Integrated Health Office, or MIHO, as people call it, is the umbrella over all of it. It's the office that contains the ARU, and it contains the case management. So the case managers that go out on the ARU are case managers who also have caseloads in our office and do follow-up case management, intensive case management. And then, so it's all under one umbrella. So the Mobile Integrated Health Office still takes, still adds people to our list over, people with overdoses, people with behavioral health crises. We take referrals from units in the field. We take referrals from police, and we get reports from the hospital also, the hospitals around opiate overdoses. So we still are running our complete programming in this office as the Mobile Integrated Health Office. And then the ARU was added as an outreach and response vehicle. Does that help?
Yeah, thank you.
Chris, I had a similar question, but I was wanting to understand the relationship with the ARU unit and the mobile crisis unit. And from my understanding, they work hand in hand. Obviously, the mobile crisis unit is covering the whole county, right? Santa Fe County, and then
Correct.
GRU is just the city.
Correct.
Did you have any other questions, Chris?
No.
Okay. Just a clarifying question with Emily. I think I couldn't figure out if this is exactly what you're talking about, but I was thinking about the involuntary, what do they call it? Involuntary commitment in California. And I know you referenced that, but I'm assuming, is that the same thing that's what California is doing? You all mentioned about involuntary commitment, but I think it was just on a general sense, but there's an actual program now, involuntary commitment in California. And if you could, I don't know if you know some information about that and how that works. And I'm assuming the reason why it works is because they have a lot more funding in California for these things, but
facilities, right? I think.
Right.
But Kate, I'll let you take that one next.
Yeah, so each state has their own legislation. I can't speak specifically to California's, but I'm guessing that it is a little bit like what's happening in New York City, where there are more first responders and law enforcement who are engaging with individuals with severe mental illness and then making the decision on their own when someone is involuntary for treatment and transporting them, which generally is a response to a massive problem, right? They have very little resources available and they're faced with that responsibility. And so they've had to develop these programs and structures to do more. Say, okay, I've decided as a police officer, you were unsafe. I'm going to take you involuntarily to the ED. And we have some small scale of that as well. What's missing, of course, particularly in our state, is where do they go? We have we have our state institute, of course, it's very small, has a low capacity, right, with staffing currently. So you have to do that very carefully. In my work, that's better done with building that rapport and relationship with the individual and helping them with something that they are voluntary for. Maybe that's a meal, or maybe it's eyeglasses, and building from there. which explains why it's such a long relationship, that we can't just strike in, remove someone from the environment involuntarily and deliver them to treatment that's actually going to be long-term stabilizing for them.
Yeah, I did. I listened to a really cool podcast about a facility in California. And there was a provider, I think she was a psychologist, who was explaining what her work environment was like. It ultimately ended up talking about kids and gun violence and stuff. But when she was describing like being able to bring somebody in and have them assessed and have them held appropriately and all of these things, I just found myself being like, that sounds nice. You know, it sounds nice to be able to have some more tools there too, and more beds and more clinicians to really do that well, so that we're not just catching and releasing people over and over again.
Thank you for that. I was just curious. I'm sure there was pros and cons, but I guess the CARE, what they call the CARE program or CARE court in California, sending people to treatment, but they have facilities to do so. And I feel like we don't have that kind of pathway. So thank you for that. I have some other stuff, but let me just go ahead and see our guest, our community guest, Sarah Grant has her hand up, sorry, and her hair up.
Thank you guys so much for being here tonight. I feel like if you really 80% of your calls are meaning that the police or the emergency room aren't involved, that is hugely successful for the police, the emergency rooms, and for the clients who don't have to get kind of freaked out because there's a policeman there, which can be scary. And so I really appreciate your work, but I'm wondering, are you guys feeling terrifically overtaxed right now? You both look relatively relaxed. And what do you guys do internally to take care of yourself so that you can keep doing this excellent work?
Wow, thank you so much for that question, Sarah. We are definitely feeling quite taxed. The level of need feels insurmountable a lot of times. I feel personally that since the ARU has been running, my sort of scope of what I'm dealing with and clinically evaluating has grown enormously. I'm very happy that we get to touch those people and find them. But it is a huge uptick in terms of what I'm used to dealing with. And then I think just driving around Santa Fe, you can see a lot of that, consistently seeing new faces on every street corner, being called by the hospital because they have a 72-year-old homeless guy who all of his cold weather gear got stolen, and we don't know him. And I'm like, who's that person? It's really intense. So I definitely am feeling that. I think in terms of taking care of myself and hopefully helping to care for my team, I think that having the supervision and support so that nobody feels like they're alone making really hard decisions and seeing really hard things, we share that weight and we support each other in doing that. We do a lot of check-ins and a lot of group staffing. We've been doing some great trainings in our staff meetings around different things, some mindfulness techniques, what all have we been doing? Lots of different stuff. So just ways that we can look at things through different lenses, so that it doesn't become quite as myopic. Kate?
Yeah, go ahead, Sarah.
Well, just one more thing, and I'm of course I'm stating the obvious, but I really appreciate what Gino said also about adolescence, because that's an age where people can be super vulnerable. I'm so glad I don't have to be an adolescent again, but at the same time, they can turn on a dime in some ways and suddenly be doing a whole lot better. And so I would just encourage the city, of course, you all know this, to invest whatever needs to happen in order to get adolescent care in order. Thanks very much for listening.
Absolutely.
I would just add to your initial question, Sarah, very much overwhelmed and taxed, and largely due to the complexity of delivering successful treatment and care to these individuals with very few resources. And I can certainly say that my time in the fire service was a very important learning experience for me, because I quickly realized that it is a beautiful functioning machine that, you know, we have built this amazing thing, this 911 response configuration, emergency services, they go out, they find you, they meet your needs to a point, right? And I became frustrated a little bit as a first responder with what I couldn't do. And I jumped out of fire into behavioral health with the intent to be able to deliver more than just, I'm going to bring you back to the ED. I'm going to bring you back to the ED, or I'm going to suggest you call this phone number and sign this refusal. It wasn't enough, particularly for behavioral health. And since I started in the field, I have built my career around what we don't have, what the barriers are, so that hopefully, and maybe we're seeing it now, we can do things differently and build what we need. So that's a heavy load, right? So Nicole has some much better answers for self-care than I do.
I don't know about that.
Mine are stepping away and having supportive coworkers and a sense of humor, and also having a realistic capture on what an outcome might be, or what a successful outcome is. Sometimes it's just harm reduction in a behavioral health sense. Maybe we're just keeping someone safe for an afternoon, and that's okay. That's success, and that's very rewarding.
Thank you for those candid responses. Any other questions? Sure, Chris.
Someone mentioned about the cold weather. Are we still providing, I think when I was there, it's probably been about 6-7 months, we were giving away sleeping bags and tents. Are we still doing that, or have we moved away from that?
We are not doing tents and sleeping bags at this point. But we got a bunch of, they're called honcho ponchos, and they're like a really good poncho jacket with the hood. So it is warm and can sort of be like a little cocoon. And we give out hand warmers, hats, gloves, socks, jackets, whatever we can get on these cold nights. I think we're running Code Blue a lot this week and over last weekend. So yeah, no more tents or sleeping bags.
Thank you.
And just to add to that, I thought there was space at the Midtown campus for folks to, because there was this misconception like, oh, you're just going to leave people out without tents or sleeping bags, but you give them resources, but there's also a place to sleep at, is it Consuelos? Okay.
Yeah, they're opening their doors at 8 o'clock on these cold nights to anyone who wants to come in. So ARU can transport people who want to go there. They can go in with their pets and they can sleep in this warm space and then, clear out the next day. But it's really low barrier and extremely helpful.
That's Consuelo's place, Valeria. I think you were asking what that was. Any other questions for folks? The only thing I would say that maybe Andres can clarify, because I was bringing up at our quality of life meeting that Las Cruces, city of Las Cruces got, and maybe it didn't exactly wasn't $1 million, but was appropriated funding for their ARU unit from our from our congressional senators, from Senator Lujan specifically. So I guess my question was like, why are we getting that funding? We already are established, and I think they're already established, but they're newer, correct? Or they
Yeah.
brand new?
Yeah, I think, I mean, some of that funding is really good to sort of pour into a newer program that's trying to build out those services. You know, we have had grant funded stuff in our office. I was grant funded for a while. And so one of our case managers has been grant funded also through the FR CARA grant. So that's an opiate related grant. So it's really good for sort of building out stuff. And I think, you know, I just got an email the other day about some behavioral health money. I think it was SAMHSA. Anyways, huge amounts of money. And I was thinking, oh my God, look at all this money. But it is, you know, it's a lot of work to write for and manage a grant. And we, in my office right now, are not in a position to spend the time doing that. We are maxed. So we'll gladly take a grant if somebody can write for it and manage it for us.
So maybe that's I don't know, I asked you this last time about wish lists and things that would be needed for MIHO, ARU, and the, you know, mobile crisis team, what would be helpful and what we could do as elected officials, especially as it relates to budget. And although maybe people don't want to say exactly here in this space to say what is not happening to support you all, would you prefer that it comes from general funds funding to support this team versus grant funded positions? Because you're right. I mean, if you don't have a grant writer, then you're spending more time trying to find funding to support your positions. And that is unsustainable in my opinion. So what else, what else could that look like for us?
Yeah, I will say that being able to move from some grant funding into hard funding stuff is huge. And I am hopeful that at some point my position will be an actual city employee position. I would gladly take that if I could. I'm very dedicated to this work, sometimes a little bit too much, but so having that hard funding, also what it does for us is it allows us to work without having to bill. And that keeps us extremely nimble. We do not have to spend the time or energy billing Medicaid or any insurance. And I've been fortunate enough that I've never had to bill for my services since I started this work 10 years ago, because I worked in places that hard funded it. So I appreciate that. I think we should continue to do that in order to keep it nimble and responsive.
And Valeria stated that just managing grants and reporting on grants, especially federal state, they're just very bureaucratic. There's a lot there. So yeah. Anything else that you want to share, feel comfortable with sharing about wish lists for us, other than the ones you listed about youth support? And I wrote them down, but we talked about them.
Yeah, and we'll send you the slides. But what did we put there? It was detox and inpatient stabilization for co-occurring. That's my big ask. Is I want some beds. That would be really, really useful for us to have a facility with some beds, so we didn't have to rely on a hospital to be the gatekeeper to that.
Yeah. Is that what just got built in Albuquerque recently? Is that a sobering facility?
I don't know. I don't know if it was or not. I need to look into that some more.
That was the only reason I know is because looking at Congresswoman Stansberry they got federal funding for that, and it's open, and she was touring it, but I wasn't sure if it was a facility that had beds as well, but it was a sobering center.
I believe that facility is off of the Haven facility and includes medical beds for people who have been released from a hospital but still need respite care, and also some a 14-day psychiatric stabilization center. And they kind of there's multiple agencies involved, and they're all on site. It's a pretty fantastic program.
Excellent.
Yeah.
Thank you for that. Is there anything else you want to share with us that we should know about as we're heading into budget season, as I asked in the last meeting?
I would just like to express my gratitude for your time and your attention. And I'd like to, as a community member and behavioral health provider, express my gratitude for the support of the mobile integrated health office, because the work that they're doing is profound and it makes everything else possible. Oh, thank you for that.
Thank you, Kate.
Mm.
Thank you to you too. We very much work as a team. Kate's part of my self-care too. I think she's the only person in my life who knows what I do and understands the intricacies of that. So peer supervision is really great. But yeah, I'm super grateful for this opportunity, and I'm really glad that the city and the county are prioritizing this. Thank you very much.
Maybe there's other recommendations that you can connect with our working group subcommittee that's on alternative responses to refine our some of our recommendations when we get to that point. And before we leave you, I'm wondering if someone could just explain, maybe there's a connection, since Marcela wasn't able to join us tonight, of how this next phase of our survey for getting public input on some of the things that people are experiencing and lived experiences. They've already gone through one phase of outreach by phone interviews. And those are randomized calls in the city of Santa Fe. And then now this next phase is a little bit more directed towards stakeholder groups. And so Emily, I don't know if you could explain maybe what you were thinking or what that could look like, so that you all are aware, see if we can make a connection or partnership there.
Sure. So the idea with the remaining surveys is to engage folks who are often least heard and have are personally impacted. And so one of the ways we've talked about doing this is reaching out to different organizations that directly work with folks that are often not surveyed. And so we've been putting together a list of those organizations. And I think we did talk about this in past meetings, that ARU or the MIHO office through the various programs would be great. And, Kate, thinking about the Crisis Triage Center, whether that was a way to do some outreach to folks who might want to engage in the survey. It's hard because, we want to make sure there's confidentiality and people feel safe doing that. And oftentimes working with someone that they know and trust is a great way to do this. So I was just recommending to add it to list, but I don't know where we are in that process. And I know Marcela knows more than I do, so.
And I apologize, Mary Louise, you might have some input as well. I'm sorry, I'm tired. I didn't get everybody.
No, that's okay. I thank you. And first, I just want to thank you for showing up and for teaching us. And I'm just so grateful that you talked about the importance of relationships. And I just want to say that first. And with that said, I really believe that you all would be an asset to this survey for many reasons. But one of them is because of the relationships that you do have with a population. And then also the knowledge that you have from what you've learned with your hands in the masa doing the work, right? And so I don't know where we are on the survey, but I hope that we could stay connected with you and your team so that you could be the voice for best practice responses that would really help us to help the community. And so that was a lot but thanks again. And I think Marcela could maybe, because she's in better communication with the guy that's in charge of the surveys that we're doing. But I hope we all stay connected.
Yeah, thank you. We certainly can. Please reach out to me any way that you need to. Be happy to do that.
We'll give you more information. Just we don't want to add more work and a workload to what you already have. So maybe there's a way to massage that. And so we'll see if someone can just make sure that Marcela gets the information that there's a maybe opportunity here. So anything else from my colleagues before we let these lovely folks go and rest for the evening, hopefully? Gino clapping.
I had one more, Renee. You mentioned about having beds, and I'm sure there may be some discussion about it around budget. Have you done any preliminary work on what the cost might be if the city were able to fund it?
We have not. We've dug into a couple of things. We were thinking about trying to model maybe a proposal around this one in California that we liked. But if we, this is sort of a work in progress, this presentation, and we are excited to add to it. So happy to look more into that.
So if there was funding available for next fiscal year, which starts in July, is that too soon? Is that putting you in a position then where maybe you're not quite ready to start?
Pete.
Well, what we do see now across the state is the push to open more crisis triage centers, right? We have ours here in Santa Fe and the one in Las Cruces, which is 23 hours, and one at UNM, which is 14 days. All of those programs can be expanded, essentially. And there is some Medicaid funding available to expand, but it has to be done carefully. You can get too top heavy by hiring too much staff and then not having the financial support that is solid, right? You have to know that you can rely on it for the next 5 years going forward as an operation. So that would be one of the reasons. For example, our center here is just 14 hours a day, and we hope to expand to 23 hours or 24 hours in the future. I think that there are probably, including ourselves, a couple of agencies that would be ready to tackle that question head on, and develop ways to find beds that are appropriately staffed.
Thank you.
Thank you. Anything else before we leave our guests this evening? Thank you both, and thank you, actually, all of you, Andres and Faith. I just really appreciate everything you do on a daily basis. It's so appreciated, even though people probably don't tell you that, but we appreciate you. Thank you.
Thank you so much for having us. Really, it's so nice to be able to share this with you and talk it through. It means a lot. Thank you.
Thank you. Andres says ditto. Thank you, task force. All right.
Thank you all.
Well, given our time here, I think we had on our agenda matters from the task force. And then after that, we had just as a placeholder working group breakouts, but given the time, I think we should skip that if it's okay with you all. And I don't know if there's anything else folks want to share. Gino. Anyone else on the task force have anything that you want to share with us? Emily.
Just wanted to share a couple of potential exciting bills, and they're going to be a lot. And I know last year we sort of looked at, well, there are going to be a lot of bills. I should have qualified. They may not all be really exciting. Some of them will be very scary, but just wanted to highlight two that I'm working on and happy to share as that, because it addresses some of the stuff we've talked about. One is an authorization bill for overdose prevention centers. So as you recall, we heard from New York's on point. And they've opened up a couple. And so we anticipate that legislation being introduced that would allow local communities to open pilots, or actually it wouldn't even have to be a pilot. It could just be a full-on program. So that's one. And the other one is
Emily, what's the name again? Authorization bill for, say it again?
overdose prevention programs. So those are the safe spaces where people can bring pre-obtained drugs to use, and they are offered wraparound services.
Great.
And then the other one is offering medication, medication-assisted treatment or opiate use disorder treatment in correctional facilities and jails. So right now, as we know, not all jails and correctional facilities offer that type of medication. So for folks who are, let's say, have a prescription for buprenorphine, which is Suboxone for an opiate use disorder, in our Santa Fe County Jail, they have to detox off their prescription medication. They're not allowed to continue that medication. And there are a lot of people that aren't even given that type of medication if they are deemed eligible. So this would actually mandate that type of treatment. So that's another, I think, really important step forward. So the two bills haven't been introduced yet, but I anticipate in the next week or two they will. So thanks.
Great, thank you so much, Emily. Any other announcements or things that folks want to share with the group? No.
Oh,
Aled.
really quick, Emily, do we have, are there numbers, like bill numbers for these things for quick reference?
Not yet. They haven't been introduced.
Okay,
So,
gotcha.
once they are, I'll send out an email.
Thank you, my friend. Thank you.
Thanks, Valeria.
And I guess the question follow up to that for our next task force meeting, which is scheduled for February 7th, do we want a specific presentation that at that meeting, whether it's updates on legislation happening and or something else? Because we don't have a presentation planned. We don't necessarily have to, but if folks could let us know if there's something that was on our list that we haven't gotten to, or if there's legislative updates that we want. And then maybe finding out where Dr. Sanchez is with the public engagement. And I don't know if we'd want him to give us an update of sorts. We could find out if he'll be ready for that.
I think, sorry to jump in again, I think that'd be great because even getting the preliminary results from the 300 surveys would be amazing.
Yes. Great, okay. So we'll make a note of that. Anything else? Any other suggestions? No? All right. There's not anything else for this evening. Our next meeting is Tuesday, February 7th at 5:30, and we won't be doing working group breakouts tonight, and then we'll get back to you about potential for the next, if we have a presentation and or if we want to just do working group work for a regular meeting time. So we could do that as well. We'll find out more from Dr. Sanchez, but I think we'll leave it at that for tonight. Thank you all. Good to see you. We'll see you soon.
Thank you
Take care of
all. Nice seeing
yourself.
all of you.
Good night.
Good night.
Night.
Valeria, I'm wondering if you can stop the recording.